Good morning. My name is Raymond Oppong. I'm a health economist at the Health Economics Unit at the University of Birmingham. And today I'm going to talk about an issue, the issue of whether the cost of antimicrobial resistance should be included in economic evaluation studies. So this is an issue which has been talked about in the past, but it's often ignored. And at the moment, because of the importance of antimicrobial resistance, the issue has become important again. So the work I present here has been published in this month's edition, the September edition of the BJGP, British Journal of General Practice, just in case you want to have a better look at the work. Okay, so this is just an outline of the presentation today. I'll give an overview of some of the issues, economic issues around antimicrobial resistance, and I'll use a case study to demonstrate whether the cost of AMR should be included when we do the economic evaluation studies. And I'll just present a discussion of the findings and maybe present some recommendations for future research. Okay, so we know AMR is associated with a high cost burden. So compared to patients who do not have resistant bugs, those who have resistant bugs have longer stays in hospitals. They use up extra treatments and investigations and are associated with higher mortality and morbidity rates. Okay, and AMR might not be a real issue if new antibiotics are being discovered or put into the market all the time. But we know this is not the case. The rate at which new antibiotics are being developed and being put into the market is slow. And so this has led to the inappropriate use of antibiotics, which has led to the reduction in the effectiveness of antibiotics over time. Okay. So economic evaluation, I'll just define it here, is a comparison of alternative courses of action in terms of their costs and their benefits. So it's used by health economists to find out whether an intervention provides value for money. And NICE also adopts these techniques. So in addition to assessing the clinical effectiveness of interventions, decision makers are also interested in finding out whether it's cost effective or not. And economic evaluation is a technique which is used. And one of the important guidance for carrying out such studies is that all relevant and important costs should be included. And health economists normally assess two types of interventions. The first is those which are aimed at curbing antimicrobial resistance and the development of AMR, such as the spread, The first is those which are aimed at curbing the spread of AMR, such as hand washing. And then the second broad techniques are those which are aimed at preventing the development of AMR. And such approaches include education. So we assess these two broad categories of interventions in AMR. However, it has been noted that when we carry out such studies, the cost of AMR is normally excluded. And one of the reasons for doing this is because the costs seem to be difficult to estimate. It's quite difficult to estimate this cost, the true cost of AMR. And sometimes people say it's intangible, so it's not high enough to warrant inclusion in our studies. However, we know this cost is not zero. So if the cost is not zero, then it means that we should include the cost of AMR when we are assessing the cost effectiveness of interventions. So from a healthcare perspective, at least some of this cost should be included. And then from a societal perspective, all the costs should be included. And if this cost is excluded, it will mean that resource allocation decisions are not done to their, it will potentially lead to inefficient resource allocation decisions, which implies that because you've excluded some costs, the intervention will appear to be less costly. And if it's less costly, it will appear to be more cost effective. Okay. So this is just a case study. It was a multinational trial looking at the harms and benefits of amoxicillin in patients with acute cough and lower respiratory tract infections. And the overall aim of the study was to assess the benefits and harms of amoxicillin in patients with LRTI. And the clinical findings, the main findings was that there was no statistically significant difference between patients who had the antibiotic amoxicillin and the control, which was placebo. So that was the main finding for the clinical study. And the aim of the economic analysis was also to assess the cost-effectiveness of amoxicillin in patients with LRTI, and also to try and experiment and see what happens when we try to include the cost of antimicrobial resistance in the analysis. Okay, so I said it before, it's a multinational RCT in 12 European countries. Okay? And so the control was placebo, and the intervention was amoxicillin. So we used standard health economic techniques. So it was a cost-utility analysis over a 28-day period. The primary outcome was the quality-adjusted life year, QALY, which is recommended by NICE. And it was carried out on an intention-to-treat basis. And what we did was estimate an ISA, incremental cost-effectiveness ratio, which is simply finding out the difference in cost between the intervention amoxicillin and the control, which was the placebo, and finding out the difference in the benefits, which was the quality-adjusted life years, and estimating the ISA, which is simply the change in costs over the change in the QALY. Okay. And so, in addition to this, the standard approach, we try to estimate the cost of AMR and include it into the economic analysis. So, as I said earlier, trying to estimate this cost is quite difficult, and methods to do this have not been developed to the full extent. So the first approach was to try and estimate a threshold based on the NICE cost-effectiveness threshold of 20,000, between 20,000 and 30,000 pounds per QALY. So at each threshold, each of the thresholds, we found out the threshold cost of resistance, which will lead to amoxicillin not being cost-effective, if that's clear. So that was the first step. And then the second step was to estimate, based on current data, the cost of resistance per prescription. And for this, we had to make an assumption that the main driver of antimicrobial resistance is antibiotic consumption and antibiotic prescriptions. So we found data from 3 sources. That's US data, we used data from the EU, and we used some global data. So we found out the costs, and then we found out the number of prescriptions, and we estimated the cost per prescription, which was given or applied to every patient who had amoxicillin or any antibiotic, irrespective of whether they were in the control or the intervention arm. Okay. So quickly, some results. So for the base case, as you can see, the cost difference between amoxicillin and the control was 2.42 pounds. So amoxicillin was more costly. It was more effective. And when we estimated the ISA, it was 6,540 pounds per QALY gained. So this showed that amoxicillin is cost-effective and represents value for money in patients with acute cough and LRTI. Okay, so that was the base case finding. And at the threshold cost of resistance, which we estimated, was 4.98 pounds for the 20,000 per QALY threshold, and 8.6 pounds for the 30,000 per QALY threshold. Okay, indicating that the cost of resistance doesn't need to be so much per patient in order to change the decision as to whether it's cost-effective or not. So this is just the summary of results. So the first, the green, is the 6,540 pounds per QALY, the base case. And using the various data sources, we can see that the ISA ranged from 175,000, and in the case where we used the EU data, it was still below the 20,000 per QALY threshold. Okay, so it showed that the cost of resistance, including it in your analysis, could make a difference to the results. And looking at the cost effectiveness acceptability curves, which shows you the probability of the intervention being cost effective at different willingness to pay thresholds. Without the cost of resistance, we can see that it appeared to be very cost effective. And when we included the cost of resistance, the probability of amoxicillin being cost effective was reduced. Okay, so this is just the curve for the global data. Okay. So the implication of the study findings is that when you are assessing interventions that include antibiotic prescriptions, if you do not include the cost of resistance, you might lead or decision makers to make maybe the wrong or inappropriate decisions or misleading decisions which are questionable. So in our case, if we didn't include the cost of resistance, we'll conclude that amoxicillin is cost effective and represents value for money in patients with LRTI. But by including the cost of resistance, we can see that this may not be the case. However, the most important thing is that there needs to be further work to be done in order to estimate the true cost of antimicrobial resistance. Because in our analysis, we needed to make a lot of assumptions because the data was just not there to feed into the study. Okay. So the problem with current estimates is that a lot of studies just consider maybe comparing patients with the resistant bugs and then those without the resistant bugs, and do not take into consideration the bigger picture or the wider societal picture. Okay? And then also, it ignores the cost of changing activities. So, for example, modern healthcare is heavily reliant on the use of antibiotics. And if antibiotics are not available in the future, then this cost has to be taken into account. So we need a scenario where we estimate the costs with and without effective antibiotics available. So there's the need to develop estimates of the cost of resistance, which should be included in economic evaluation studies. And this will also help antibiotic stewardship. However, there's methodological issues, such as how best do we estimate this cost. There's a lot of uncertainty around the estimates of this cost. And there's issues about uncertainty in terms of modeling under a lot of scenarios. Okay. So these are some references. The first one is the paper which has just been published in this month's edition of the BJGP. And the second reference is a paper which was published in 2013, which tried to estimate talk about the true cost of antimicrobial resistance. And the last reference is the clinical results of the case study that I've just presented. Thank you very much. Okay.